Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about the anterior abdominal wall, the inguinal canal, and we're also going to talk a bit about celiac disease and inflammatory bowel disease. Lastly, we're going to touch on bowel cancer, the pathology, and some screening processes. Okay, I'm here with Grok, who's going to be explaining this material to us. Take everything with a pinch of salt. Make sure you cross-reference anything you listen to. And yeah, I hope you find it enjoyable and informative. So, Grok, let's start with the anterior abdominal wall and the inguinal canal. And I think a good place to start is with the boundaries of the abdominal cavity, so we can kind of structure where everything lies on.
All right, let's dive into the anterior abdominal wall and the inguinal canal, starting with the boundaries of the abdominal cavity to set the stage. The abdominal cavity is a space that houses most of the digestive organs, and its boundaries give us a framework for understanding the structures we're talking about. Superiorly, it's bounded by the diaphragm, which separates it from the thoracic cavity. Inferiorly, it extends to the pelvic brim, where it transitions into the pelvic cavity. Anteriorly, we've got the anterior abdominal wall, which is our main focus today, a layered structure of skin, fascia, muscles, and peritoneum. Posteriorly, the boundary includes the lumbar vertebrae, psoas, and quadratus lumborum muscles. Laterally, the abdominal wall curves around, formed by the same muscular layers we'll get into. Now, zooming in on the anterior abdominal wall, it's like a protective curtain made up of several layers. From superficial to deep, you've got skin, subcutaneous tissue, like Camper's and Scarpa's fascia, then the muscles external oblique, internal oblique, and transversus abdominis, followed by transversalis fascia, extraperitoneal fat, and finally the parietal peritoneum. These muscles are key for movement, stability, and housing structures, like the inguinal canal. Speaking of the inguinal canal, it's a short, oblique passage through the lower anterior abdominal wall.
Okay, I'm just going to remind you, Grok, this is great stuff. Keep everything efficient and effective and concise. Try to answer with the minimum amount of words that gets the point across. Okay, so we have the pelvic inlet inferiorly and the superior, and superiorly we have the diaphragm. Can we talk a bit about the innominate bones too? So they break down to the ilium, the pubis, and the ischium. And the ilium is superiorly, and then the ischium is posteriorly to the pubis. Is this correct? Is the bony part that goes out and I can feel my pubis? Is that right or not? Maybe it's wrong, I'm not sure. Or is it the ischium? The ones that are anterior.
You're on the right track, but let's clarify the innominate bones and their positions concisely. The innominate or hip bone is made of three fused bones: ilium, ischium, and pubis. The ilium is the superior, broad, wing-like part, forming the upper pelvis. The ischium is posterior and inferior, including the sit bones you feel when sitting. The pubis is anterior, meeting at the pubic symphysis in the midline. So, what you're feeling anteriorly is likely the pubis, not the ischium. The ischium is farther back.
Or is it the iliac fossa? Maybe it's the iliac fossa that I'm feeling? Maybe like the anterior superior iliac spine, or no?
Let's clear this up. The iliac fossa is a smooth, concave surface on the inner side of the ilium, deep within the pelvis, so you can't feel it externally. What you're likely feeling is the anterior superior iliac spine, ASS, a prominent bony landmark on the front of the ilium. It's easily palpable at the top of your pelvis.
The inferior or the superior one?
You're referring to the iliac spine, and it sounds like you mean the anterior superior.
No, I'm asking the bony part that I can feel that in layman's terms we call hip bone. Which part of the innominate bones is it?
bony part you feel, often called the hip bone in layman's terms, is most likely the anterior superior iliac spine, ASS, of the ilium, part of the innominate bone. It's the prominent point at the front of your pelvis, on either side, just below your waist.
Okay, that makes sense.
So,
Okay,
we've got the
let me ask you about the pelvic girdle then. What is this? And the sacrum. Hey dude, pelvic girdle, sacrum, inguinal ligament, the pubic tubercle, coccyx, let's put them together.
All right, let's tie these together concisely. The pelvic girdle is the ring-like structure formed by the two innominate bones, each with ilium, ischium, pubis, and the sacrum, which is the triangular bone at the base of the spine, made of 5 fused vertebrae. The coccyx, or tailbone, is a small, curved bone just below the sacrum, made of 4 fused vertebrae. The pubic bones of the innominate bones meet anteriorly at the pubic symphysis, a cartilaginous joint. The inguinal ligament stretches from the anterior superior iliac spine, ASS, of the ilium to the pubic tubercle on the pubis, forming the floor of the inguinal canal. Together, these structures stabilize the pelvis, connect the spine to the lower limbs, and support the abdominal and pelvic organs.
Can you explain me the etymology? Are you confused where these etymologies come from? Why you name them such? Like how the etymologies relate to the physical location? Pubic tubercle, for instance, coccyx, inguinal ligament, sacrum.
Let's break down the etymology of these terms and how they relate to their physical locations or functions, keeping it concise. Pubic tubercle comes from Latin, pubis, groin or pubic region, and tuberculum, small swelling. It's a small, bony projection on the pubis, near the groin, accurately describing its location and shape. Coccyx, from Greek kokix, from cuckoo, because its shape resembles a cuckoo's curved beak. It's the small, tail-like bone at the spine's base, fitting its appearance. Inguinal ligament. Inguinal ligament comes from Latin pubis, from Greek coccybus. Inguinal ligament, derived from Latin inguine, groin. It spans the groin area, from the ilium to the pubis, reflecting its position in the inguinal region.
Okay, fair enough. Okay, and we've got a few regions. We've talked about them in other podcasts too. We've got epigastric, hypogastric, umbilical. Pull a picture up, guys. 9 regions of the abdomen. We have the flank, lumbar, left and right in the middle, and then we have hypochondriac, and we've got the inguinal, which makes sense. Okay.
So, you're talking about the 9 regions of the abdomen, which help map out the abdominal cavity for clinical and anatomical purposes. Since you mentioned a picture for your podcast, I'll describe them clearly to paint that mental image. The abdomen is divided into 9 regions by 2 vertical lines, midclavicular lines, and 2 horizontal lines, transpyloric and transtubercular planes. From top to bottom, left to right. Top row, right hypochondriac below ribs, liver, gallbladder area. Epigastric, central, stomach, pancreas, left hypochondriac, spleen. Middle row, right lumbar, flank, ascending colon, umbilical, central, small intestine, left lumbar, descending colon. Bottom row, right inguinal, groin, appendix, hypogastric, suprapubic, bladder.
Okay.
Left.
That's okay, it's okay. Okay, let's talk a bit about the layers of the abdominal wall. Okay, we start with the skin. And we have a superficial fatty layer. We call it Camper's fascia. Who was Camper?
All right, let's hit the layers of the anterior abdominal wall, focusing on Camper's fascia.
Yeah, and remember, for the next 100 replies you give me, I want you to be as concise, effective, and efficient with your words as possible. Keep it short.
Got it. Anterior abdominal wall layers. Skin, Camper's fascia, superficial fatty layer. Scarpa's fascia, deeper membranous layer. External oblique, internal oblique, transversus abdominis, transversalis fascia, extraperitoneal fat, paradial peritoneum. Camper was Petrus Camper, 18th century Dutch anatomist who described this fatty fascia in the groin and lower abdomen. Want more on any layer?
And we have transversus abdominis, transversalis fascia, extraperitoneal fat, parietal peritoneum. Okay. I'm not completely sure of the order, but we can go deeper to it when we do, because this is going to be a short podcast when we just kind of talk a bit, describe a bit about the structures. We can go deeper on them on another one. But the main muscles are basically external, internal obliques, transversus abdominis, and rectus abdominis.
You're spot on with the main muscles. Order of layers, superficial to deep. Skin, Camper's fascia, Scarpa's fascia, external oblique, internal oblique, transversus abdominis, rectus abdominis medially, transversalis fascia, extraperitoneal fat, paradial peritoneum. Main muscles, external oblique, internal oblique, transversus abdominis, rectus abdominis. We can dive deeper into any structure for your podcast. Just let me know which.
Okay. And I'm very bad with understanding origins and insertions. Also, remind us the linea alba, is it the line? But yeah, I'm very bad with origins and insertions. But maybe let's give it a shot. If you could kind of try to explain to us the origins, why the external oblique, internal oblique, and transversus abdominis have the origins and insertions that they have.
All right, let's tackle the linea alba and the origins, insertions of the external oblique, internal oblique, and transversus abdominis simply. Linea alba is the tough, fibrous midline band where the rectus abdominis and oblique aponeuroses meet, running from xiphoid to pubic symphysis. External oblique, origin, lower ribs, 512. Insertion, linea alba, pubic tubercle, iliac crest. Why? Fibers run downward forward, aiding torsoflexion and rotation, pulling from ribs to pelvis midline. Internal oblique, origin, iliac crest, thoracolumbar fascia. Insertion, lower ribs, 1012, linea alba. Why? Fibers run upward forward, supporting rotation and compression, anchoring to pelvis and pulling to ribs midline. Transversus abdominis, origin, iliac crest, thoracolumbar fascia, lower ribs, 712. Insertion, linea alba, pubic crest. Why? Fibers run horizontally, compressing abdomen, stabilizing core from lateral pelvis ribs to midline. These setups maximize movement and core stability. Want more on actions?
It's a bit confusing, I can't lie. So, and the pyramidalis, explain us the pyramidalis and rectus abdominis' origin and insertions, why they are the ones they are. Just a bit confusing, because I don't understand with what criteria we choose them, you know?
I hear you. Origins and insertions can be tricky. Let's simplify the pyramidalis and rectus abdominis, explaining their origins, insertions, and why they're set up that way. The criteria for origins, fixed point, and insertions, moving point, depend on which end stays stable during muscle contraction, usually based on function and leverage. Rectus abdominis, origin, pubic symphysis, pubic crest. Insertion, xiphoid process, costal cartilages, 5-7. Why? Runs vertically along the midline, so when it contracts, the pubic origin is more fixed, pelvis is stable, and the insertion pulls the chest down, flexing the spine, like in crunches. Pyramidalis, origin, pubic crest, anterior to rectus abdominis. Insertion, linea alba, midway up. Why? Small, triangular muscle that tenses the linea alba when contracting, with the pubic origin fixed and the linea alba insertion moving slightly to stabilize the midline. The setup reflects their roles: rectus for major flexion, Pyramidalis for subtle linea alba tension. Clearer now? Want to focus on one?
Not really, but what is the general principle? Like, if I didn't know the origins of and insertions of things, what's the general principle that I need to think that might give me a clue on what the origin and insertion might be?
The general principle for determining origins and insertions is the origin is the fixed or more stable attachment point, usually closer to the body's center or larger bone, while the insertion is the more mobile point, typically farther from the center or on a bone that moves. Think about the muscle's action, what it pulls or moves. The origin stays put, often on a broader or less mobile structure, and the insertion moves toward it during contraction. For example, abdominal muscles often originate on the pelvis or lower ribs, stable, and insert on the midline or upper ribs, movable, to flex or rotate the trunk. Consider the direction of pull and which end is anchored. Need a specific example?
It's so good. Okay. And let's talk a bit about the rectus sheath now. What's the rectus sheath? And what's aponeurosis?
The rectus sheath is a fibrous envelope formed by the aponeuroses of the external oblique, internal oblique, and transversus abdominis, enclosing the rectus abdominis muscle. An aponeuroses is a flat, tendon-like sheet of connective tissue that anchors muscles to bones or other structures, like the broad, flattened tendons of the oblique and transversus muscles. Above the arcuate line, the sheath has anterior, external oblique, plus half internal oblique, and posterior, half internal oblique plus transversus layers. Below, all aponeuroses form the anterior sheath, with only transversalis fascia posteriorly. It stabilizes and supports the rectus abdominis. Clear? Want more details?
I don't get it.
Okay, let's simplify. The rectus sheath is like a sleeve around the rectus abdominis muscle. It's made from aponeuroses, flat, tough sheets of tissue from the external oblique, internal oblique, and transversus abdominis muscles. Think of aponeuroses as wide, thin tendons. The sheath wraps the rectus abdominis to hold it in place and help it work. Above the belly button, the sheath splits to cover the rectus front and back. Below, it's only in front. This setup supports core strength. Makes sense now? Want me to focus on one part?
Yeah, that makes sense actually. Okay, and what about the rectus sheath? So we have anterior. Do you have anterior and posterior rectus? Is one thing?
Good. Glad it's clicking. The rectus sheath is one structure, not separate anterior and posterior rectus muscles. It's a single fibrous sleeve around the rectus abdominis, made from the aponeuroses of the oblique and transversus muscles. It has two parts, the anterior layer, front of the rectus, and posterior layer, back of the rectus. Above the arcuate line, near the belly button, the anterior layer is external oblique plus half of internal oblique, and the posterior is half of internal oblique plus transversus. Below the arcuate line, all aponeuroses form the anterior layer, and the posterior layer is just transversalis fascia. One sheath, two layers, encasing one rectus abdominis. Clear now? Want specifics on any part?
That makes sense. Okay, let's talk a bit about the innervation of the abdominal wall then. So, let's talk a bit about the thoraco-abdominal nerves, and then the subcostal nerves, and then the iliohypogastric, ilioinguinal. They kind of make sense in terms of location, because, you know, they reflect where they are in the body.
All right, let's cover the innervation of the anterior abdominate wall, focusing on the thoraco-abdominis, subcostal, iliohypogastric, and ilioinguinal nerves. Thoraco-abdominate nerves, T7, T11, come from intercostal nerves, running between internal oblique and transversus abdominis, innervating the rectus abdominis, obliques, and transversus, plus skin from the xiphoid to above the pubis. The subcostal nerve, T12, follows a similar path, supplying the lower abdominate muscles and skin just above the groin. Iliohypogastric, L1, splits off, innervating the skin over the iliac crest and upper groin, plus some abdominate muscles. Ilioinguinal, L1, travels through the inguinal canal, supplying skin of the scrotum, labia, and medial thigh. Names reflect locations. Thoracoabdominant for chest to abdominant, subcostal below ribs, iliohypogastric, ilioinguinal for iliac, groin regions. All provide motor and sensory functions. Clear? Need more on any nerve?
No, that makes sense. Okay, what about, let's talk a bit about some arteries that I'm not very familiar with, like superior
All-
epigastric artery. Are they bilateral? What about musculophrenic? What about inferior epigastric? Deep circumflex iliac artery, superficial circumflex iliac, femoral. Are these bilateral?
Let's clarify these arteries and whether they're bilateral. Superior mesenteric artery, single, unpaired artery from the aorta, supplies midgut, small intestine, proximal colon, not bilateral. Inferior mesenteric artery, single, unpaired from the aorta, supplies hindgut, distal colon, rectum, not bilateral. Musculophrenic artery, bilateral, branches from internal thoracic arteries, supplies diaphragm and upper abdominal wall. Deep circumflex iliac artery, bilateral, from external iliac arteries, supplies lower abdominal wall and iliac region. Superficial circumflex iliac artery, typically bilateral, from femoral arteries, supplies superficial groin skin, all paired arteries. Musculophrenic, deep circumflex iliac, superficial circumflex iliac exist on both sides, reflecting body symmetry. Clear? Want details on any?
No, that makes sense. And with the inguinal canal then, we have a deep inguinal ring and a superficial inguinal ring. What is this?
The inguinal canal is a 4-6 centimeter oblique passage in the lower anterior abdominal wall. The deep inguinal ring is its internal opening, a slit in the transversalis fascia, where structures, spermatic cord in males, round ligament in females, enter the canal. The superficial inguinal ring is the external opening, a triangular gap in the external oblique aponeuroses, where these structures exit toward the genitalia. Think of them as entry, deep, and exit, superficial points of a tunnel. Clear? Want more on their anatomy or function?
Superficial is the exit. And where do they come from?
Yes, the superficial inguinal ring is the exit of the inguinal canal, where structures like the spermatic cord, males, or round ligament, females, emerge. The deep inguinal ring is the entrance, where these structures originate from inside the abdomen, passing through the transversalis fascia. They come from abdominal contents. In males, the spermatic cord, vas deferens, testicular vessels, starts from the testes descent during development. In females, the round ligament begins at the uterus. Clear?
Yes.
Need more?
Okay, question. What's the conjoint tendon? And talk to us a bit about the borders of the inguinal canal too.
The conjoined tendon, or conjoint tendon, is a fused structure formed by the aponeuroses of the internal oblique and transversus abdominis, inserting into the pubic crest and pectineal line. It strengthens the posterior wall of the inguinal canal. Inguinal canal borders: anterior wall, external oblique aponeuroses; posterior wall, transversalis fascia and conjoined tendon; roof, internal oblique and transversus abdominis fibers; floor, inguinal ligament, folded external oblique aponeuroses. These create a 4-6 centimeter tunnel for the spermatic cord or round ligament. Clear? Want details on any border?
No, that makes sense. And we have the descent of the gonads from the inguinal canal. And where do they come from, these gonads? What's the gubernaculum?
The gonads, testes in males, ovaries in females, originate in the embryo near the kidneys on the posterior abdominal wall. During fetal development, they descend. Testes pass through the inguinal canal to the scrotum, guided by the gubernaculum. Ovaries move into the pelvis. The gubernaculum is a fibrous cord connecting the gonads to the scrotum or labia majora, acting like a guide rope to direct descent. In males, it helps form the scrotal ligament. In females, it becomes part of the ovarian and round ligaments. Clear? Want
Yeah,
more
that
on
makes sense. Okay, question. What's the cremaster muscle? And tell me about the external spermatic fascia, dartos fascia, and internal spermatic fascia, tunica vaginalis.
The cremaster muscle is a thin layer of skeletal muscle derived from the internal oblique, covering the spermatic cord and testes in males. It contracts to elevate the testes for temperature regulation. External spermatic fascia, outermost layer of the spermatic cord, an extension of external oblique aponeuroses. Internal spermatic fascia, innermost layer, from transversalis fascia, encasing cord structures. Dartos fascia, smooth muscle layer in the scrotum, continuous with Scarpa's fascia, responsible for scrotal wrinkling. Tunica vaginalis, a peritoneal sac covering the testes, formed during testicular descent, reducing friction. All protect and support testicular structures. Clear?
Mm-hmm.
One.
Yeah, that makes sense.
Glad it's clear. Anything else on the inguinal canal or abdominal wall you want to dive into for your podcast?
Well, I want to learn a bit about the contents of the inguinal canal, like the spermatic cord, arteries, veins, nerves they have.
The inguinal canal contains the spermatic cord in males, or round ligament in females. Spermatic cord contents: testicular artery, from aorta, supplies testes. Pampiniform venous plexus, drains testes. Cremasteric artery, small, from inferior epigastric. Vas deferens, carries sperm. Genitofemoral nerves genito branch, innervates cremaster scrotal skin. Testicular nerves, sympathetic, for sensation, and lymphaticks, drain to para-aortic nodes. These are bundled in 3 fascial layers: external spermatic, cremasteric, and internal spermatic fascia. In females, the round ligament and ilioinguinal nerve pass through. Clear?
Mm-hmm.
Want specifics on any structure?
It's all good. Okay, let's jump topics to celiac disease. Give us an introduction on what celiac disease is.
Celiac disease is an autoimmune disorder where gluten, a protein in wheat, barley, rye, triggers an immune response that damages the small intestine's lining, impairing nutrient absorption. It causes symptoms like diarrhea, bloating, fatigue, and can lead to complications if untreated. Managed with a strict gluten-free diet. Clear? Want more on causes or symptoms?
No, that makes sense. Okay.
All right. So, we've got celiac disease as an autoimmune issue with gluten damaging the small intestine.
And what and who gets celiac disease? Like how is it getting? How is it caused?
Celiac disease affects about 1% of people, often those with genetic predisposition, HLA-DQ2 or HLA-DQ8 genes. It's triggered by gluten ingestion in genetically susceptible individuals, causing an immune reaction that attacks the small intestine's villi. Environmental factors, like early gluten exposure or gut infections, may contribute. It can develop at any age, more common in females and those with family history or other autoimmune disorders, e.g., type 1 diabetes. Clear? Want more on risk factors or triggers?
I want to ask you about tissue transglutaminase and diamidates glutamine gliadin and how they connect to gluten.
Gluten, a protein in wheat, barley, and rye, contains gliadin, a component that triggers celiac disease in susceptible people. In the gut, gliadin is partially broken down into peptides. Tissue transglutaminase, TTG, an enzyme in the intestinal lining, modifies these gliadin peptides by deamidating them, removing amide groups, creating deamidated gliadin peptides. These altered peptides bind strongly to HLA-DQ2 or DQ8 molecules on immune cells, sparking an autoimmune response that damages the small intestine. So, gliadin starts it, TTG amplifies it, and deamidated peptides drive the immune attack. Clear? Want more on the immune response?
Makes sense. And what about IL-15 and yeah, so basically is it an autoimmune disease thing? What's going on?
Yes, celiac disease is an autoimmune disorder. Gluten, specifically gliadin, triggers an immune response in genetically predisposed people, HLA-DQ2, DQ8. Tissue transglutaminase modifies gliadin, making peptides that activate T cells. IL-15, a cytokine, amplifies this by boosting immune cell activity and inflammation in the small intestine, damaging villi. This autoimmune attack causes symptoms and malabsorption. Clear? Want more on IL-15's role or other cytokines?
Makes sense. So let's talk a bit about the side effects of celiac disease.
Celiac disease can cause gastrointestinal side effects like diarrhea, bloating, abdominal pain, and weight loss due to small intestine damage and malabsorption. Systemic effects include fatigue, anemia, iron deficiency, bone loss, calcium vitamin D issues, and skin rash, dermatitis herpetomorphis. If untreated, it risks complications like infertility, neurological issues, or increased lymphoma risk. Symptoms vary widely, and some people are asymptomatic. Clear?
What about things like anemia, osteopenia, emaciation? What are these?
Celiac disease can lead to anemia, low red blood cells, often from iron, B12, or folate malabsorption, causing fatigue, pallor, weakness. Osteoporosis, weak, brittle bones from poor calcium and vitamin D absorption, increasing fracture risk. Emaciation, severe weight loss and muscle wasting due to chronic nutrient malabsorption, leading to a gaunt appearance. These stem from the damaged small intestine's inability to absorb nutrients properly. Clear? Want more on any
No,
of
to
these?
be honest, it's not clear. If you could kind of tell me again in a sentence. I don't know what osteopenia and emaciation are either.
Celiac disease causes anemia, low red blood cells from poor iron, B12 absorption, leading to tiredness, osteoporosis, weak bones from calcium vitamin D malabsorption, risking fractures, and emaciation, extreme weight loss and muscle wasting from nutrient malabsorption, causing thinness. These happen because the damaged small intestine can't absorb nutrients.
Okay,
Clear now? Want to focus on one?
let's shift focus to bowel cancer. Now, if you could explain what it is, link it to... I'm interested to see how fiber affects it. And tell us other things that you think are important regarding bowel cancer. Please.
All right, let's break it down simpler. Celiac disease damages the small
No, dude,
intestine.
I asked you about bowel cancer. I said, can you make us an introduction to bowel cancer and also explain to me how it links with fiber and yeah.
Apologies for the mix-up. Bowel cancer or colorectal cancer is a malignancy in the colon or rectum, often starting as polyps that grow abnormally. Low fiber intake is a risk factor. Fiber speeds up stool transit, reduces carcinogen exposure, and promotes healthy gut bacteria, lowering cancer risk. Insufficient fiber can increase inflammation and cell mutation chances. Clear? Want more on causes or prevention?
Tell me about also hyperplastic polyps and tubular adenomas, villus adenomas, tubulovillus adenomas, dysplasia. How do these relate? I don't even know what these things are, so if you could explain what they are and tell us how they link to bowel cancer.
All right. Let's break down hyperplastic polyps, tubular adenomas, villus adenomas, tubulovillus adenomas, and dysplasia, and they're linked to bowel cancer. Keeping it simple. Hyperplastic polyps, small, common growths in the colon, usually benign with low cancer risk, especially if small and in the lower colon. They rarely turn cancerous. Tubular adenomas. Tubular adenomas tends to push against the yonder, most near cancerous. Tubular adenomas, most common precancerous polyps, 70% of adenomas, with tube-shaped gland structures. Less than 9% become cancerous, but larger ones, or those with dysplasia, raise risk. Villus adenomas, larger, cauliflower-like polyps with finger-like projections, about 15% of polyps, with higher cancer risk, up to 38% due to faster growth and larger size. Tubulovillous adenomas, mix of tubular and villus features, with intermediate cancer risk, 19%. Risk depends on size and dysplasia. Dysplasia, abnormal cell growth in polyps, graded low or high. High-grade dysplasia looks closer to cancer, increasing cancer risk, but isn't cancer yet. Linked to bowel cancer. Adenomas, tubular, villus, tubulovillous, are precancerous. They can slowly transform into colorectal cancer over years, especially if large, villus, or with high-grade dysplasia. Hyperplastic polyps are usually low risk and less large or serrated. Regular screening removes these polyps to prevent cancer. Clear? Want more on
That
any
makes sense. So what's the adenoma carcinoma sequence?
The adenoma carcinoma sequence is the process where a benign adenoma, tubular, villus, or tubulovillous polyp in the colon progressively transforms into colorectal cancer. It starts with a normal colon lining developing a polyp due to genetic mutations, e.g., APC gene. Over years, further mutations, KRAS, TP53, cause dysplasia, abnormal cell growth. Low-grade dysplasia can become high-grade, then invade deeper layers, becoming adenomata, cancer. Most colorectal cancers, 60-80%, follow this sequence, preventable by removing adenomas during screening. Clear? Want details on mutations or prevention?
No, that makes sense. And, okay, what is familial adenomatous polyposis then?
Familial adenomatous polyposis, FAP, is a rare genetic condition caused by a mutated APC gene, leading to hundreds to thousands of adenomas, precancerous polyps, in the colon and rectum, usually starting in teens. Without treatment, like colon removal, nearly 100% develop colorectal cancer by age 40. It's inherited, autosomal dominant, and may also cause polyps elsewhere, like the stomach. Regular screening and surgery prevent cancer. Clear? Want more on genetics or management?
I don't get what it is though.
Familial adenomatous polyposis, FAP, is a genetic disorder where a faulty APC gene causes hundreds to thousands of precancerous polyps to grow in the colon and rectum from a young age. If untreated, these polyps almost turn into colorectal cancer. It's passed down in families, and surgery is often needed to prevent cancer. Clear now? Want to focus on any part?
So which defective gene is it?
Familial adenomatous polyposis, FAP, is caused by a mutation in the APC gene, adenomatous polyposis coli. This defective gene fails to regulate cell growth, leading to numerous polyps in the colon and rectum. Clear? Want more on how it drives polyp formation?
No, that makes sense. Okay, and how does it link to CHR5Q21? And tell us also about the two-hit hypothesis.
Familial adenomatous polyposis, FAP, is linked to the APC gene on chromosome 5q21, chromosome 5, long arm, region 21. Mutations here disrupt cell growth control, causing polyps. Two-hit hypothesis. In FAP, one mutated APC gene is inherited, first hit, leaving cells with one functional copy. A second mutation, second hit, in the remaining APC gene and colon cells disables it completely, triggering uncontrolled cell growth and polyp formation, which can lead to cancer. This explains why FAP patients develop many polyps early. Clear? Want more on genetics or cancer progression?
That makes sense.
I'm glad it's clear.
Okay,
Want to
tell us a bit more about this and explain to us also how the second hit leads to loss of heterozygosity.
Familial adenomatous polyposis, FAP, is caused by an inherited mutation in one APC gene copy on chromosome 5q21. The two-hit hypothesis explains polyp formation. The first hit is the inherited mutated APC gene, leaving one functional copy, heterozygous state. The second hit is a somatic mutation or deletion in the remaining functional APC gene in a colon cell. This second hit causes loss of heterozygosity, LOH, where the cell loses the normal APC allele, leaving only the mutated version. Without functional APC, cell growth control fails, leading to adenoma formation and eventual cancer risk. LOH often occurs via chromosomal deletion, non-disjunction, or recombination. Clear? Want more on LOH mechanisms or FAP progression?
That's okay. So, hereditary non-polyposis colorectal cancer is Lynch syndrome. Let's talk about that a bit.
Hereditary non-polyposis colorectal cancer, HNPCC, also called Lynch syndrome, is an inherited condition caused by mutations in DNA mismatch repair genes, MLH1, MSH2, MSH6, PMS2. These mutations impair the body's ability to fix DNA errors, leading to a high risk of colorectal cancer, up to 80% lifetime risk, often before age 50. And other cancers, endometrial, ovarian, stomach. Unlike FAP, it involves few or no polyps. It's autosomal dominant, diagnosed via genetic testing or Amsterdam-Bethesda criteria. Screening and early detection are key. Clear? Want more on genes or screening?
Tell me about the genetics of Lynch syndrome.
Lynch syndrome is caused by inherited mutations in DNA mismatch repair genes, MLH1, MSH2, MSH6, PMS2, or rarely EPCAM, which affects MSH2. These genes normally fix DNA replication errors. Mutations, autosomal dominant, lead to defective repair, causing microsatellite instability, MSI, where DNA segments repeat abnormally, increasing cancer risk, especially colorectal and endometrial. Most cases involve MLH1 or MSH2 mutations, 70-80%. Genetic testing confirms diagnosis. Clear? Want more on MSI or testing?
I see. And tell me more about this Amsterdam criteria.
The Amsterdam criteria are clinical guidelines to identify families likely to have Lynch syndrome. Amsterdam 2 criteria require at least 3 relatives with Lynch-associated cancers: colorectal, endometrial, small bowel, ureter, or renal pelvis. 1 a first-degree relative of the other 2, at least 2 successive generations affected, at least 1 cancer diagnosed before age 50, and exclusion of familial adenomatous polyposis. Meeting these flags a high chance of Lynch syndrome, prompting genetic testing. Clear? Want more on Bethesda criteria or diagnosis?
No, that makes sense. Okay. Let's go back to to celiac disease and let's talk a bit about the investigations for celiac disease.
All right. Assuming you mean chronic inflammatory gastrointestinal CIG diseases, like inflammatory bowel disease, IBD, including Crohn's disease, and
No, I
ulcerative...
said celiac disease.
My bad. Let's focus on investigations for celiac disease. First line, blood tests for anti-tissue transglutaminase, TTG-IgA, and anti-endometrial antibodies, EMA-IgA, highly specific for celiac. Total IgA levels ensure test accuracy. If positive, A duodenal biopsy via endoscopy confirms villus atrophy. HLA-DQ2, DQ8 genetic testing may support diagnosis, but isn't definitive alone. Gluten challenge required if already gluten-free. Clear? Want details on any test or next steps?
I don't get the investigation, so what will the doctor do? Tell me again.
For celiac disease, the doctor starts with blood tests, anti-tissue transglutaminase, TTG-IgA, and anti-endometrial antibodies, EMA-IgA, to detect autoimmune markers. They check total IgA to ensure the tests work. If positive, they do an endoscopy to take a small intestine biopsy, looking for villus damage. If you're gluten-free, you may need to eat gluten before testing. Genetic tests, HLA, DQ2, DQ8, can support but don't confirm. Clear? Want me to focus on one step?
That makes sense. Okay. Now I want to ask you, what are the microscopic features of celiac disease then?
Microscopic features of celiac disease in the small intestine, seen on duodenal biopsy, include villus atrophy, flattened villi, crypt hyperplasia, elongated crypts, increased intraepithelial lymphocytes, more immune cells in the lining, and lamina propria inflammation, immune cell
Okay,
infiltration.
villus
These
atrophy
change-
and crypt hyperplasia. Explain these two to me. Why do we see these things?
Villus atrophy. The small intestine's villi, finger-like projections that absorb nutrients, flatten or disappear due to autoimmune attack, triggered by gluten, reducing surface area for absorption. Crypt hyperplasia. The crypts, glands at the villi base, elongate as the intestine tries to regenerate lost villi, but the ongoing immune response prevents recovery. These happen because gluten activates T cells via tissue transglutaminase and HLA-DQ2, DQ8, which damage the intestinal lining in genetically susceptible people. Clear? Want more on the immune process?
So, guys, you'll see me instantly, but I'm taking a break. So, let's talk a bit about the complications of celiac disease, shall we?
All right, let's focus on celiac disease complications. If untreated, it can lead to malnutrition due to nutrient malabsorption, anemia, iron, B12, folate deficiency, osteoporosis, calcium vitamin D loss, infertility, neurological issues, neuropathy, seizures, dermatitis herpetiformis, itchy skin rash, and increased risk of small bowel lymphoma or other cancers. Strict gluten-free diet prevents most of these. Clear? Want details on any complications?
No, that makes sense.
Cool, got it. Want to explore celiac disease management, like gluten-free diet specifics, or jump to another topic for your podcast?
I want to ask what constitutes inflammatory bowel disease now. So it's Crohn's disease, ulcerative colitis, diverticular disease, ischemic colitis.
Inflammatory bowel disease, IBD, primarily includes Crohn's disease and ulcerative colitis, chronic conditions causing gut inflammation. Diverticular disease, inflamed diverticula, and ischemic colitis, colon inflammation from reduced blood flow, are separate conditions, not classified as IBD, though they can mimic symptoms. Crohn's affects any part of the digestive tract, mouth to anus, often patchy, with deep inflammation. Ulcerative colitis affects only the colon and rectum, with continuous mucosal inflammation. Both are autoimmune, with genetic and environmental triggers. Clear? Want details on any of these?
No, that makes sense.
Glad it's clear. Want to dive into Crohn's or ulcerative colitis specifics, or switch to another topic for the podcast?
Okay. Let's talk a bit about Crohn's disease then. Explain a bit more what it is. Explain also the genetics too, what causes it.
Crohn's disease is a chronic inflammatory bowel disease causing inflammation anywhere in the digestive tract, often ileum colon, with patchy deep lesions leading to abdominal pain, diarrhea, weight loss, and fatigue. Genetics. Over 200 gene variants increase risk, notably NOD2, CARD15 mutations, impaired immune response to gut bacteria. It's not solely genetic. Environmental triggers, smoking, diet, infections, and gut microbiome imbalance combine with genetic predisposition to cause an overactive immune response, driving inflammation. Clear? Want more on symptoms or triggers?
No, that makes sense. Okay. So what environmental factors are implicated in Crohn's disease?
Environmental factors linked to Crohn's disease include smoking, increases risk and severity. High-fat, low-fiber diets disrupt gut microbiome. Infections like Mycobacterium or E. coli, triggering immune response. Stress may worsen symptoms, and living in industrialized areas. Higher exposure to processed foods or pollutants. These interact with genetic predisposition and gut bacteria to drive inflammation. Clear? Want details on any factor or management?
No, that makes sense. Okay.
All right, cool. Want to keep going with Crohn's, maybe symptoms or treatment, or switch to another topic for your podcast?
Let's talk a bit about the morphological features of Crohn's disease.
Crohn's disease has distinct morphological features. Transmural inflammation, affecting all gut wall layers, skip lesions, patchy areas of inflammation, granulomas, non-caseating in 30% of cases, fistulae, abnormal connections between gut and other structures, abscesses, and cobblestone mucosa, ulcers and swollen tissue resembling cobblestones. These occur anywhere from mouth to anus, often in the ileum colon, causing pain, diarrhea, and complications. Clear? Want more on any feature or diagnostics?
Okay. So we have fat wrapping of the serosa, and then so we give rise to, what are skip lesions?
Skip lesions in Crohn's disease are patchy, discontinuous areas of inflammation in the digestive tract where disease segments are separated by healthy tissue. Unlike ulcerative colitis, continuous inflammation, Crohn's leaves skipped normal areas, seen in the mucosa or deeper layers, often in the ileum or colon. This pattern helps diagnose Crohn's and contributes to its variable symptoms. Clear? Want more on fat wrapping or other features?
Oh, makes sense. And what's ulceration of the mucosa?
Ulceration of the mucosa in Crohn's disease refers to erosions or sores in the inner lining, mucosa, of the digestive tract, often in patchy areas, skip lesions. These ulcers result from chronic inflammation damaging the mucosal layer, leading to pain, bleeding, and diarrhea. They can deepen, causing fissures or fistulae, and contribute to the cobblestone appearance when surrounded by swollen tissue.
And what are strictures?
Strictures in Crohn's disease are narrowed segments of the digestive tract caused by chronic inflammation and scar tissue buildup in the gut wall. They often occur in the small intestine or colon, leading to partial or complete bowel obstruction, causing pain, bloating, and difficulty passing stool. Strictures may require medication or surgery to relieve. Clear? Want more on complications or treatment options?
What's cobblestone?
Cobblestone mucosa in Crohn's disease refers to the appearance of the gut lining, where deep, linear ulcers alternate with swollen, inflamed tissue, resembling a cobblestone street. It results from chronic inflammation and ulceration, typically seen in the small intestine or colon during endoscopy. This pattern causes pain and bleeding. Clear? Want more on how it's diagnosed or treated?
I don't get what it is.
Cobblestone mucosa in Crohn's disease is when the gut's inner lining looks bumpy, like a cobblestone path. It happens because deep ulcers form between areas of swollen, inflamed tissue due to ongoing inflammation. Seen in the small intestine or colon, it causes pain and bleeding. Clear now? Want to focus on visuals or diagnosis?
Well, I want to talk a bit about the microscopic appearances of Crohn's disease. So, yeah, go for it.
Microscopically, Crohn's disease shows transmural inflammation, immune cells infiltrating all gut wall layers, non-caseating granulomas, clusters of immune cells, in 30% of cases, lymphoid aggregates, dense immune cell patches, fissuring ulcers, deep mucosal cracks, and crypt abscesses, pus and glandular crypts. These features, seen in biopsies, reflect chronic inflammation and help diagnose Crohn's. Clear? Want details on any feature or diagnostic use?
So what do we mean when we say transmural inflammation?
Transmural inflammation in Crohn's disease means inflammation extends through all layers of the gut wall, from the mucosa, inner lining, to the serosa, outer layer. This deep inflammation, seen microscopically with immune cell infiltration, causes ulcers, fistulae, and strictures, distinguishing Crohn's from ulcerative colitis, which only affects the mucosa. Clear? Want more on its effects or diagnosis?
I don't get it.
Okay, simpler. Transmural inflammation in Crohn's means the entire gut wall, inside lining to outer layer, gets inflamed, not just the surface. Immune cells attack all layers, causing deep damage like ulcers or fistulae. This is why Crohn's can cause more severe complications than diseases affecting only the inner lining. Clear now? Want to focus on an example?
Yes, okay. Okay, let's talk a bit about the complications of Crohn's disease. So we have abscesses, we have ulcers, what else?
Complications of Crohn's disease include abscesses, pus pockets from deep inflammation, ulcers, sores in the gut lining, fistulae, abnormal connections between gut and other organs or skin, strictures, narrow gut segments causing blockages, bowel obstruction, malnutrition due to malabsorption, colorectal cancer, increased risk with long-term inflammation, and perianal disease, fissures, abscesses near anus. Clear? Want details on any complication?
No, that makes sense. Okay, let's talk a bit about ulcerative colitis, shall we?
Ulcerative colitis, UC, is a chronic inflammatory bowel disease causing continuous inflammation and ulcers in the mucosal lining of the colon and rectum. Symptoms include bloody diarrhea, abdominal pain, and urgency. Unlike Crohn's, it doesn't affect deeper gut layers or skip areas, starting at the rectum and spreading proximally. Genetic, HLA genes, immune, and environmental factors, e.g., diet, stress, drive it. Clear? Want more on causes or symptoms?
I don't get what it is, to be honest. What's the difference between this and Crohn's disease? How do I distinguish it? What is the difference in causes and clinical features?
Okay, let's clarify ulcerative colitis, UC, and compare it to Crohn's disease, simply. Ulcerative colitis is a chronic disease causing inflammation and ulcers only in the colon and rectum's inner lining, mucosa, always continuous, starting at the rectum. Crohn's disease can affect any part of the digestive tract, mouth to anus, with patchy, deep inflammation through all gut wall layers. Differences? Location, UC, colon, rectum only, continuous. Crohn's, anywhere, patchy, skip lesions. Depth, UC, mucosa only. Crohn's, transmural, all layers. Causes, both involve genetics, UC, HLA-DR, Crohn's, NOD2, and environmental triggers, diet, smoking, stress. UC is more tied to autoimmune mucosal attack, Crohn's to dysregulated immune response and gut bacteria. Clinical features, UC, bloody diarrhea, urgency, tenesmus, feeling of incomplete evacuation, Crohn's, diarrhea, less bloody, abdominal pain, weight loss, fistulae, strictures.
Can you summarize in a sentence? I'm confused.
Ulcerative colitis, UC, inflames only the colon rectum's inner lining continuously, causing bloody diarrhea, while Crohn's disease affects any digestive tract part with patchy, deep inflammation, leading to diarrhea, pain, and complications like fistulae.
I see. Okay, and what are the macroscopic? Okay, well, you kind of told us the macroscopic. So basically, you're saying that in ulcerative colitis is mainly the colon that we have problems with, like ulcers and inflammation, whereas Crohn's might be any part.
Exactly. Ulcerative colitis, UC, causes continuous ulcers and inflammation only in the colon and rectum's inner lining, mucosa. Crohn's disease can involve any part of the digestive tract, mouth to anus, with patchy, deep inflammation across all gut wall layers. Macroscopically, UC shows red, granular mucosa with ulcers in the colon. Crohn's has cobblestone mucosa, skip lesions, and fistulae, anywhere. Clear? Want to dive into microscopic features or something else?
Okay.
All right. Want to keep going with ulcerative colitis? Maybe its microscopic features or treatment? Or switch to another topic for
Yeah,
the podcast?
sure. Let's do that. And then let's talk a bit about the normal mucosa and the crypt architecture distortion when we have ulcerative colitis.
The normal colonic mucosa has a smooth, uniform surface with straight, evenly spaced crypts, tubular glands, that reach the muscularis mucosae, lined by goblet cells producing mucus. In ulcerative colitis, UC, the mucosa becomes inflamed, red, and granular, with ulcers and pseudopolyps, inflamed tissue growths. Microscopically, UC causes crypt architecture distortion. Crypts become irregular, branched, shortened, or dilated due to chronic inflammation and immune cell infiltration. You also see crypt abscesses, pus in crypts, goblet cell depletion, less mucus, and mucosal erosion. These changes reflect ongoing damage and repair attempts. Clear? Want more on UC complications or treatment?
I want to ask you about
Cool. What's up? Want to stick?
I want to ask about the extraintestinal manifestations of these diseases, like ocular uveitis, aritis, and cutaneous arthropathies.
Extraintestinal manifestations, EIMs, of inflammatory bowel diseases, Crohn's disease, and ulcerative colitis affect areas outside the gut. Common ones include joints, peripheral arthritis, pain swelling in knees, ankles, tied to gut inflammation, axial arthropathy, spine, sacroiliac joints, like ankylosing spondylitis. 1. Infections, uveitis, chocolates. 2. Eyes, uveitis, eye inflammation causing pain, redness, vision issues, episcleritis, milder eye redness. 2. Skin, erythema nodosum, painful red nodules, often on legs, pyoderma gangrenosum, ulcerating skin lesions. Liver, Primary sclerosing cholangitis, bile duct inflammation, more common in UC. These occur due to immune system dysregulation, often paralleling gut activity, though some, like PSC, progress independently, affect up to 40% of IBD patients.
Okay.
Clear?
Okay. Can we talk a bit more about how to differentiate between CD and UC, Crohn's disease and ulcerative colitis? For instance, I want to focus on the transmural versus mucosal aspect and on the complications.
All right, let's differentiate Crohn's disease CD and ulcerative colitis UC, focusing on transmural versus mucosal involvement and complications. Transmural versus mucosa. CD causes transmural inflammation, affecting all gut wall layers, mucosa to serosa, leading to deep ulcers, fistulae, and strictures, seen anywhere from mouth to anus, often patchy, skip lesions. UC affects only the mucosal layer of the colon rectum, causing continuous superficial ulcers and inflammation, starting at the rectum. Do as I would do and put it into rectum tolerance. Make sure the changes are clear. Complications. CD, fistulae, gut to skin connections, strictures, narrowed gut causing blockages, abscesses, malnutrition, perianal disease.
Okay. Yeah. Summarizing a sentence, the differences, the complications.
Got it. Crohn's disease CD has transmural inflammation, all gut layers, patchy, mouth to anus, causing fistulae, strictures, abscesses, malnutrition, perianal issues, and colorectal cancer risk. Ulcerative colitis UC has mucosal inflammation, colon rectum only, continuous, leading to bloody diarrhea, pseudopolyps, toxic megacolon, and higher colorectal cancer risk with long-term disease. CD's deep damage causes more structural issues. UC's superficial damage causes severe mucosal bleeding and systemic risks. Clear? Want more on diagnosis or treatment differences?
No, that's good. Okay, let's talk a bit about bowel cancer now. Actually, before we do that, tell me 5 keywords for complication differences for ulcerative colitis versus Crohn's.
5 keywords for complication differences: Crohn's, fistulae, strictures, abscesses, perianal disease, malnutrition. Ulcerative colitis, toxic megacolon, pseudopolyps, severe bleeding, colorectal cancer, primary sclerosing cholangitis. Clear?
Yeah.
Ready to move to bowel cancer?
Let's do it. Yeah.
Awesome. Want to jump into bowel cancer now, or stick with anything else on Crohn's or
Yes. Let's jump.
All right. Bowel cancer. Colorectal cancer is a malignancy of the colon or rectum, often arising from adenomatous polyps. Risk factors include low fiber diet, obesity, smoking, and genetic conditions like Lynch syndrome or FAP. Symptoms: blood and stool, changed bowel habits, abdominal pain, weight loss. Screening, colonoscopy, catches it early. Clear? Want more on causes, types, or screening?
No, that makes sense.
Cool, got it. Want to dive deeper into bowel cancer, like its stages, treatments, or maybe how it links to IBD, or something else for the podcast?
I want to ask you about the staging of bowel cancer. So we have tumor, we have lymph node metastasis, we have distant metastasis.
Bowel cancer, colorectal cancer staging uses the TNM system. Tumor, T. T1 to 2, tumor invades submucosa or muscularis propria. To 3 to 2-4, tumor penetrates deeper layers or nearby organs. Lymph node, N. N0, no lymph node involvement. N1 and 2, Cancer in nearby lymph nodes, 1, 3, or 4 plus. And metastasis, M. M0, no distant spread. M1, cancer in distant organs, liver, lungs. Stages, 0 in situ to IV, distant metastasis. Staging guides treatment and prognosis. Higher stages mean worse outcomes. Clear? Want details on stages or treatment?
Okay, yeah, I do. So we have invasion of the submucosa. This and why is the muscularis propria clear? Is that inner or outer, the muscularis propria?
The muscularis propria is the middle muscularis layer of the colon rectum wall, made of inner circular and outer longitudinal smooth muscle, responsible for peristalsis. In bowel cancer staging, T1, tumor invades submucosa, layer just below the mucosa, inner lining. T2, tumor reaches muscularis propria, middle layer. It's not the innermost, mucosa, or outermost, serosa layer. Clear? Want more on staging progression or T3 to 4?
I don't get it, to be honest.
No worries. Let's simplify. The colon wall has layers: mucosa, innermost lining, submucosa below mucosa, muscularis propria, middle, thick muscle layer for movement, and serosa, outermost. In bowel cancer, T1 means the tumor is only in the submucosa, just under the surface. T2 means it's reached the muscularis propria, the muscular middle layer, but not beyond. Muscularis propria is central, not inner or outer. Clear now? Want to focus on another staging part?
That's good. Okay.
Awesome. Glad it clicked. Want to keep going with bowel cancer staging? Maybe lymph nodes or metastases?
So when we have
Or-
this invasion, it starts from the inner to the outer or the other way around?
In bowel cancer, tumor invasion typically starts from the inner layer, mucosa, and progresses outward. It begins in the mucosal lining, often as a polyp, invades the submucosa, T1, then the muscularis propria, T2, deeper layers or adjacent structures, T3 to 4, and potentially spreads to lymph nodes or distant organs. The spread is inward to outward through the colon wall. Clear? Want more on spread pathways or staging?
I wonder.
Curious, huh? What's on your mind? Want to dig deeper into how bowel cancer spreads? Explore another aspect?
No,
or
I
switch?
want to ask you about bowel cancer screening.
Bowel cancer screening aims to detect colorectal cancer or precancerous polyps early. Common methods? Colonoscopy. Gold standard. Visualizes entire colon. Removes polyps. Recommended every 10 years from age 50. Earlier for high-risk groups. Fecal occult blood test, FOBT, or fecal immunochemical test, FIT. Detects hidden blood in stool. Done annually, non-invasive, prompts colonoscopy if positive. Sigmoidoscopy examines lower colon, less invasive, every 5 years. CT colonography, imaging scan, every 5 years, less invasive but requires follow-up colonoscopy if abnormal. Screening reduces mortality by catching cancers early. High-risk groups, family history, IBD, start earlier. Clear? Want details on any method or risk groups?
I want to ask you about what's fecal immunochemical test.
Fecal immunochemical test, FIT, is a non-invasive screening tool for bowel cancer that detects hidden blood in stool, a possible sign of cancer or polyps. You collect a small stool sample at home and send it to a lab where it's tested for hemoglobin using antibodies. Done annually, if positive, it prompts a colonoscopy. It's specific for human blood, more accurate than older FOBT, and doesn't require dietary restrictions. Clear?
Yeah,
Want
but how do exactly they do it?
With a fecal immunochemical test, FIT, you get a kit with a small brush or stick and a collection tube. You wipe the brush on a stool sample from a bowel movement, place it in the tube with a preservative solution, and seal it. You send the sample to a lab, where it's tested for human hemoglobin, blood, using antibodies and an automated analyzer. Results show if blood is present, indicating possible bowel cancer or polyps, prompting a colonoscopy. Takes a few minutes at home, done annually.
And what and what's a polyp?
A polyp is a growth protruding from the mucosa membrane, often in the colon or rectum. In bowel cancer, polyps are typically adenomas, tubular, villous, or tubulovillous, or hyperplastic. Adenomas are precancerous, potentially turning into cancer over years if not removed. Hyperplastic polyps are usually benign, but can rarely be cancerous if large or serrated. Found and removed during colonoscopy, they're key to preventing colorectal cancer. Clear?
Yes.
One.
Thank you for watching, guys.